Hello, welcome back. We're going to continue talking about psychosocial integrity by discussing chemical dependency. Now, the U.S. seems to be a drug-oriented society. Two-thirds of the adult population uses alcohol regularly. Approximately 14% of American adults have either had a problem with alcohol dependence or alcohol abuse at some point in their lives. Even if you never work in psych, you will have the experience of dealing with a client who is chemically dependent. A couple of concepts you need to keep in mind when dealing with a chemically dependent person, and the first are the concepts of addiction. Addiction is loss of control of a substance ingestion. These clients will use the substance despite associated problems, and they have a tendency to relapse. Now, if you're dealing with a client who is dependent, they end up developing a tolerance to the substance. They need a higher and higher dose to achieve the desired effect, and they also experience withdrawal after long periods of use, so that stopping or reducing the amount of the substance causes physical and psychological signs and symptoms. The first chemical we're going to talk about is alcohol-related disorders. What you need to know are the symptoms of intoxication and withdrawal, implementation for intoxication and withdrawal, and you need to know the central nervous system disorders associated with chronic alcohol abuse. Alcohol is a central nervous system depressant, and the signs and symptoms that are listed here will also apply to a client who was taking benzodiazepines, chloral hydrate, or meprobamate. If the client is experiencing acute alcohol intoxication, you will see drowsiness, slurred speech, tremors, impaired thinking, belligerence, and a loss of inhibitions. Now, it's very important if you happen to be caring for a client who is experiencing acute alcohol intoxication, you need to first and foremost protect the airway and assess the client for injuries. You will monitor vital signs frequently and allow the client to essentially sleep it off. You will also be assessing for signs and symptoms of withdrawal. You may assess the need for IV glucose and counsel about alcohol use. Now, when you counsel about alcohol use, it's very important that you deal with these clients in just a matter-of-fact, non-judgmental way. What was consumed, how much, how long have you been drinking, how often do you drink, and what kinds of problems has this caused you in your life? Let's talk about alcohol withdrawal. Alcohol withdrawal occurs when one stops drinking after prolonged heavy use. The symptoms develop a few hours after cessation or reduction of the alcohol. Indications of alcohol withdrawal are tremors, insomnia, anxiety, hallucinations. You may also see an elevated heart rate, diaphoresis, insomnia, and illusions. And illusions is misinterpreting objects in the environment. For example, maybe there's a patterned wallpaper on the wall and the person thinks that it's killer bugs. It's important for you to know that the symptoms of alcohol withdrawal peak after 24 to 48 hours, and then they rapidly disappear unless the withdrawal progresses to alcohol withdrawal delirium. Alcohol withdrawal delirium is a medical emergency. What you're going to see is disorientation, paranoia, ideas of reference, suicide attempt, or grand mal seizures. In addition, the client may have an elevated pulse, they may have the visual or tactile hallucinations with fluctuating levels of consciousness. Now, delirium usually peaks after 48 to 72 hours after the cessation or reduction of the intake and may last for 2 to 3 days. Now, if you are caring for a client who's experiencing either alcohol withdrawal or alcohol delirium, it's important that you monitor vital signs hourly. The pulse is a good indication of the progress through the withdrawal process. So if the client's pulse has been within normal limits and now elevates, it may indicate an impending alcohol withdrawal delirium. It's important that you may administer sedation, and they will be given a sedation that's chemically equivalent to the alcohol. Also, the medication will control the overactivity of the sympathetic nervous system. Anticonvulsants may or may not be used. If the client has a history of seizures, they certainly will be given anticonvulsants. They may also be given IV or IM thiamine to prevent Wernicke syndrome. When caring for the client who's experiencing alcohol withdrawal and or delirium, you want to make sure and put them in a well-lighted room to prevent the illusions. And remember, the illusions is misperceiving or misinterpreting what is there. It's important that you stay with your patient, back to that, to increase orientation and to minimize confusion and anxiety. It's also important that you decrease environmental stimuli, no radios, no television, and only one visitor at a time. Now, if you're dealing with a client who has a chronic alcohol dependence, what happens with these people is daily drinking increases in amount. So they will have a persistent incapacitation. There will be cyclic drinking or binges. What you'll find with a family that has a family member with chronic alcohol dependence, others in the family take over the client's role. And also, chronic alcohol dependence is many times a factor in family violence. Now, if you are dealing with a person who's chronically dependent or addicted to alcohol, you're going to see some very predictable defense mechanisms used. They will use the defense mechanisms of rationalization, projection, and denial. They also display some characteristic behaviors of conflict minimization and avoidance, passivity. They're very passive, and they're also very manipulative. The aim of treatment for somebody with chronic alcohol dependence is self-responsibility. Now, if you're a nurse dealing with this client, you need to develop a warm, accepting relationship with the client so they can feel safe enough to start looking at their problems. It's important that you identify the problems related to the drinking. You know, what kind of problems has your drinking caused you? Help the client to see the problems. You also want to help them establish control of the problem, and this will be done through Alcoholics Anonymous, which is a self-help group that follows a 12-step program. Also, the client may be given antabuse, which is a drug that if the client ingests any alcohol at all, they have this violent physical reaction. It's very important that you counsel the spouse and children of the chronic alcoholic, because they've probably taken over responsibilities for the person, and they're probably codependents, or they're taking responsibility for the client. So referring them to Al-Anon and Alateen is many times very helpful. Wernicke syndrome is an encephalopathy that's associated with the thiamine deficiency of a chronic alcoholic. You may see confusion, diplopia, nystagmus, ataxia, and apathy. If you have a client who has been diagnosed with Wernicke syndrome, it's very important to administer IM or IV thiamine, and also counsel this client about the importance of abstaining from alcohol. Another central nervous system illness that you may see with the alcoholism is Korsakoff psychosis. This is a secondary dimension that is also caused by the thiamine deficiency, and it's associated with prolonged heavy alcohol ingestion. Indications of Korsakoff psychosis include memory disturbance with confabulation. And confabulation is making up stories or answers to maintain self-esteem when a person doesn't remember something. So this isn't lying. They're just making things up to protect their self-esteem. Clients with Korsakoff psychosis may have learning problems. They may have altered taste and smell, and a loss of reality testing. When you're caring for a client with a diagnosis of Korsakoff psychosis, it's important that you offer them a balanced diet or encourage them to eat a balanced diet. You will give them IM or IV thiamine and also counsel regarding the importance of abstaining from alcohol.